Welcome back to the Damn Parenting Podcast. I am your host, Eva, and I'm glad you're here with me for this one. Okay, real talk. If you're in the Netherlands and you're pregnant, there is a very specific cultural pressure that can come with that. And it rhymes with thuisbevalling, home birth, the gold standard, the Dutch way. And look, if that's your path, beautiful, truly. But what if it's not? What if you need a cesarean or you want one and you're left feeling like you somehow failed the test before you even got to a hospital? Well, that is exactly the conversation we need to have. And it's exactly why I'm re-airing this episode today in honor of International Cesarean Awareness Month. I'm talking about episode 31 from 2 years ago, and it features, well, one of the most genuinely exciting humans I think I've had on this show, Dr. Koen Deurloo, a gynecologist at the Diakonessenhuis Utrecht, and the man who basically said, what if a C-section could still feel like a birth? Because the thing that no one really tells us is, a cesarean doesn't have to be something that happens to you. Dr. Deurloo pioneered what's called a mother-assisted cesarean, where the birthing parent gets to physically participate in bringing their baby into the world. We're talking 4 extra minutes, 4. And those 4 minutes, they can completely change what this experience means to you. Since we first aired this episode, Dr. Deurloo, well, he's performed hundreds of more mother-assisted births and published his book, Door de Ogen van de gynecoloog. Well, that's a mouthful. Well, he's basically been actively training even other gynecologists across the Netherlands to offer this option too. And well, the man is out here changing the system from the inside. And honestly, I am here for every second of it. So whether you're planning a C-section, maybe you just want to be ready for every possibility, or you just want to hear something, or you just need to be reminded that your wishes for your birth matter. This one is for you. Welcome back to the Damn Parenting Podcast. Let's get into it. Dr. Deurloo, welcome.
Thank you. Thank you for having me.
We're delighted to have you because our podcast is all about getting the experts and shining a light and getting some answers and facts directly from the professionals themselves here in the Dutch medical system. As it's the Cesarean Awareness Month, we thought, who better to invite but yourself to come along? Dr. Deurloo himself is actually an expert on the Ouders van Nu magazine, which a lot of us will be aware of, and also How About Mom. Mm-hmm. So he is well versed to the media side, I guess, of being a doctor as well. Yeah. And how about you give us a little introduction about yourself?
Well, thank you. So it's nice to have this invitation, and I really like to be here. So I'm a OB-GYN, so a gynecologist in Utrecht, in the Diakonessenhuis. And I'm actually a perinatologist, which is just a fancy word for a gynecologist who specializes in obstetric care. So a lot of pregnant women, a lot of deliveries, and a lot of C-sections. Studied in Leiden University. I got my PhD in Amsterdam, did some internships in The Hague, and now finally landed in Utrecht. So for over 10 years now. So good place to be.
That's always a good thing to hear as well. So anyone in Utrecht looking to give birth, that's always a good thing to hear. I think actually the first question is we're actually going to do is let's distinguish between an elective C-section and an emergency C-section.
That's a very frequently asked question. So it's good to start with that one. Elective C-sections are just planned C-sections. So we know before the delivery, we know it's going to be a C-section. And that's because the women want that for various reasons. And sometimes it's impossible to give normal birth because you have a placenta blocking the exit, or you have a difficult position of the baby, feet position, feet down. And sometimes you have you had a previous C-section and you'd like to give birth by another C-section. So then we know during pregnancy that you want a C-section, and then we can plan it, and we call that the elective C-section. It's about the half of all our C-sections. So the other half is unplanned. So, or as you like, emergency, but emergency sounds a bit scary. So unplanned C-sections are usually C-sections which we encounter during delivery. So during delivery, we notice that labor is not progressing, the dilation stops, or the baby doesn't descend, or we do find problems with the condition of the mother, which is quite rare, or problems with the condition of the baby, which is more common. And then we need to decide to give birth by cesarean because we don't have any more time to wait.
I think that's pretty simple then explanation, I guess. So thank you for that. So this is going to be for basically all the listeners out there who really want to understand this process. As an international woman, we come here, and if we're going to give birth here, Obviously, the Netherlands is the land of home birth. I don't know why, considering of the stairways some of the houses have here. But can you explain to us, how does the Dutch healthcare system approach the decision-making process for the elective cesarean section?
Yes, we are the country of home birth, but you have to think about our country as being really, really small. So every home is really close to a hospital. Yes, so it's not like in the US, you have to drive for miles. So and it's a little bit in our culture, just like the tulips and the cheese, and so just the home deliveries as well. And we got some really professional midwives who are very experienced in home deliveries. So we have a very safe environment for home deliveries. But we do see women who would like to discuss elective C-section. And first of all, they need to tell that wish to their midwife. And usually their midwife refers them to me or to my colleagues. And then we'll discuss their opinion, their wishes concerning C-section. And we have a medical list: breech presentation, early C-section, placenta previa, so placenta blocking the exit. And it's very easy to plan a C-section, but we also have women who say, I want to give vaginal birth because I'm really scared, I'm traumatized, or another way. And we also invite these women also in our offices to discuss their wishes, and we grant them also.
Our midwives are going to refer us to you, and then we go through a series of questions. And can you explain to us what actually happens in that meeting?
In the referral from your midwife, usually there's this little text where they explain to us from what they need from us, what they would like us to discuss with the pregnant woman. And during their visit, we'll discuss their wishes. So if you want elective C-section, why would you think that's a good idea? Can you explain to me why this is helping you? So I think personally, if in a planned C-section, the benefits, the risks, and the disadvantages outweigh the benefits, the risk, and disadvantages of vaginal birth, we need to plan a C-section. So, but you need most of the time a gynecologist just to put everything in a weighing scale to see what's the best option for you.
And is there any scenario where they would say, we don't do it, we're not going to do it, or we're not going to make it easy? Or is there also any concern from the insurance company? Do they say, well, there is no medical reason, we have this list, we have to prove if a gynecologist doesn't tick these boxes, then you have to pay out of pocket or anything? Or is that like an urban myth that's out there?
That's something I don't recognize. With all the women I performed C-section, we haven't had any problems with our insurance company. So they'd like us to have a good shared decision with these women. So make a good choice. And if the best choice is C-section, then we're going to do a C-section.
Reassuring for all these opinions that are out there, because some of them I've read, they're very scared, but they think they don't have a valid reason. I'm putting this in quotations, but the reason for them obviously is valid. So they might be scared to present that and be denied. So it's good to hear that if you have a reason, then let's go on and plan it.
And sometimes there can be reasons not to perform a C-section, usually when the condition of the mother doesn't allow it, or the risks for the baby or the mother are way bigger than the risk of vaginal birth. But still, if you tell them that and they still want C-section, there's something behind that. There's a wish or concern or a trauma. You need to address that. Most women just think, have their own solution made up. So when they come to you with their solution, but they don't know all these solutions. So they need me to go through all these solutions. And sometimes we change.
So after this first appointment with you, where you're doing a balancing act of pros and cons, as it were, do they need to make a second appointment with you?
Sometimes there's not a definite need, so it's not mandatory. Sometimes most women do need some time. They hear new things. Sometimes they're a little bit surprised over, my elective C-section is possible. And then I'd like to talk to them again. So how can we fill in your C-section? How can we make that a nice experience for you? And sometimes they are in doubt. Is a C-section really a better option for me? Okay, I'll just give them some time. So we like the referrals in an early stage of pregnancy. So for all the women listening, please don't wait till 36 weeks. Then it's kind of like emergency planning.
That's what I was going to ask is, what week is it that you would actually do a C-section for planned?
Well, whenever the woman is ready. So most of the women are ready at the earliest at 20 weeks. They had the NAPT screening, they had the first trimester scans, the second trimester scan. So they know the baby's going to be okay. And then there's room in their heads to think about birth. So that's usually from 20 weeks on. And some would like to plan it close to 24 weeks because they have a lot of wishes or a lot of concerns. And some of them, they know what they want. They've done it before and they say, oh, I'll just wait till 34 weeks. Even if you come early or late, you can still stay with your midwife. Just do the decision-making with me. The supervision and monitoring is done by your midwife.
What week will they give birth?
If you have a planned C-section, usually we plan that a week before term date. So that's about 39 weeks. But it depends.
And the other thing is, I don't know if this is from American TV or not, but it's like usually people are like, I'm going to choose this date because it meant something to me. How does that work here?
The same.
Oh, really? We get to choose our own dates?
Well, you cannot choose all the dates because, first of all, C-section need to be safe and at the right time. If you're going to do too early, baby might not be ready yet, so it can have difficulty breathing. If you wait too long, you still have your contractions. You have a lot of pain, you need to come to the hospital, wait with pain. So there's this half-week interval to plan a C-section. So they're usually a couple of days. And then there's also our logistics. But we do have women who say, this is the birth of my father. I'd rather have another date. Sure, if it's possible. Yeah, we look into that. Or they lost someone. It's a special date for them. So sure, of course, we'll try.
You mentioned there about the midwives. Can you actually explain what is the role of the midwives now that if they are going to move into the C-section process?
Depends on the midwife, but we work really close together. So in Utrecht, we have a very strong organization to work with women who have wish for a C-section. So most of the times they monitor these women until 36 weeks or so, and then they come over to my hospital and have one more appointment and then their planned C-section. But some midwives keeps them monitored until the planned C-section, which is really nice. But well, they're really busy, so they don't always have room for these women. And some women say, well, I have a lot of questions, a lot of concerns. I'd like to have the next few appointments in the hospital. So from 32 weeks or 30, that's okay too. It's all about what's good care. Yeah. What would you like? If you'd like to discuss, I can do monitoring also. It's more about logistics. So if it's easy for you to come to the hospital, talk about your C-section and have me monitoring your pregnancy, fine. If you just want to come to the hospital once or twice, then your midwife can still monitor your pregnancy.
The thing here is you're with your midwife until you're planning or whatever. And then normally you could be transferred then to a medical team. So that's the thing is then that's the moment that they're deciding that if they're going to go medical or not, if they stay with their own or if they move to your team.
Usually when the referral, and it could be a little bit early in pregnancy, so 24 weeks or a little bit later, then we'll discuss how to proceed from there. How many appointments do you need with me? Would you like me to take care of you for monitoring your pregnancy? Would you like to stay with your midwife? And I call the midwife. Is it okay that she stays with you until the planned C-section? Do you still have room for her? So that's how it usually works. Yeah.
Okay. Can you even give us a few of the criteria or factors that are considered when determining if a C-section is appropriate for a mum? Because you mentioned there earlier about if it was healthy for the mother themselves as well. Is there anything that you're going to be able to say, well, this is actually plays a key function in our decision?
Well, we have the simple method, which we use a couple of variables to estimate the chances of success of successful delivery, usually after C-section. So the chances of giving successful birth is an important argument for women to try for another natural birth or to opt for elective C-section. And I usually consider the pros and the cons. So a C-section is planned, so no contractions, so you can have a good night's sleep, come to the hospital, delivered in an hour. So those are all good things. But you need to recover for 6 weeks. So that's a con. And if you planning to have a big family, you might need more C-section, maybe 2, maybe 3, maybe 4. That's a con too. So you can look at another way to the vaginal birth. It's a pretty big deal. It's like a marathon. So it's going to take you a lot of effort, a lot of pain. But if you succeed, your recovery is much quicker. Yeah, it's much healthier. And if you're planning a big family, it gets easy over time. So you can even avoid multiple C-section if you opt for normal delivery. So, and those variables success rate, recovery rate, the difficulty of delivering, those subjects in the appointment when women come to my to talk about C-sections. We don't have a list and say, you're good, you're not. So we just go through our list and see, what do you think of this? What do you think of that? So what's appropriate for your family? How is your family planning? What do you think is important in giving birth? Some women say, I think it's something which makes women powerful, so I want to give birth. So that's a good argument, I think, to give birth. But some women say, I don't mind. I just want to deliver by C-section. I don't care. I'm still a good mom. That's fine too. So, but that's 1-0 for the C-section. So that's how you do these counselings.
It's very nice to hear that you also take these, I'd say, soft factors into account. Like you said, like, this is very powerful. How does it make you feel? What do you wish out of it? It's not just the medical side, like, okay, this is all the medical stuff. Yes, no, yes, no, yes, no. Yeah. But you really sounds like you take a holistic approach. Let's make the best decision from all angles, and maybe one of them will sway then into one or the other direction when they realize, oh, actually, well, I haven't thought of this, and then my decision might sway in another direction. That's very nice.
Yeah, that's it. So it's just not about this one decision. It's also about your whole family, about your recovery. So there's more. If you choose a C-section, you will probably choose for your future deliveries also C-section. Most women are not aware of that. So it's pretty logic, but...
Yeah, that's very true. I mean, we all have to go through it once to be able to understand what's going to be happening to us in the future. Moving into the, as you called it, the unplanned C-section, not the emergency C-section. Yeah. Can you explain the protocols of these cesareans then in Dutch hospitals? For example, like when you have breech. So you were saying it's not all about the Grey's Anatomy aspect of rushing through hospital wards, but can you give us an insight then into what's then in the protocol?
Yes, definitely. So during delivery, you always think what's best for the baby and what's best for the mom. And if everything goes fine, you'll just wait. So you don't need stimulation, you don't need epidural, you don't need anything. Just coach her, motivate her. So, but once progression slows down, then you need to reconsider what's best for the baby now. Do we need oxytocin, so stimulation of the contraction, which has side effects, which has risks? Or do we think this is too big of a risk for the baby or the mother? Should we consider C-section? So usually midwives discuss these things with you. And sometimes they refer these women to me to discuss these things. So if you are going to give birth, this is what's going to happen. We're not going to do all the scenarios, but we have the most likely scenarios. What if there's no progression? What if you need pain relief? What there is meconium? What your membranes are current for more than 24 hours? And then we let them think, what do you think is good for you when you have a lot of pain? Sometimes it's help when they have previous experiences. They say, well, I don't know, morphine didn't work with me. I'd rather have epidurals. Okay, we'll make a wish list or birth plan, and we put this down. So whenever you're tired and working hard on your delivery, you don't need to tell us what you want. We already know, you told us.
So when we're either at home or we're in the hospital and we're in the midst of what's happening and C-section wasn't on our list.
Yeah, well, I think with approximately 10% or so chances of getting a C-section during delivery, it should be on your list. It's also my message for all the women out there. Of course, I don't want that to happen, but 10% is a realistic risk during delivery to get a C-section. So a lot of you are all informed about NIPT test, are about 20-week scans. Chance of getting a baby with an abnormality is 1% or 3%. So don't skip the 10% risk of a C-section. It's really important. So, and if you're really afraid or you find it difficult, well, come to me. So I'm there. So are my colleagues. So I love to talk about C-sections.
And then what measures are in place to ensure timely access to these unplanned sections when they're necessary?
Well, we have the whole medical team close to the hospital. And I think about 90% stays in the hospital. And the rest of them live so close to the hospital, they're fast as they were if they were in the hospital. So usually within 15 minutes, we can get your baby out. Yeah, that's code 1. So if we're really worried about the condition of the baby, we have this code. We say code 1, and then all the elevators stop in the right position. The doors open. We don't run still, but we walk really hard and really fast. And that's a team we got 24/7 available. 15 minutes, yeah.
Quick. Well,
that's quick. Yeah,
it's an emergency.
We train that. We train that. Every other hospitals do that too.
Are there any actual specific differences in the approach to unplanned or emergency sections compared to the elective ones within the Dutch healthcare system?
Well, if it's planned, then it's more of a relaxing experience. You can take the time. You can comfort parents when they're in the operating room, which is a pretty scary place for most people. When you're in an emergency or unplanned C-section, even if you thought about it in your birth plan, you still, it's your first time in an operating room. Most of the women are healthy and never been there, and it's good. And that's a little bit scary. And in emergency, there's less time to comfort everybody. So we'll still try, but sometimes we are in a rush, so we need to get the baby out. So that I find that difficult sometimes. So with planned C-section, we try a more gentle, easy, relaxing way. We take lots of time to comfort parents, and in the emergency, it's not always possible. If it's possible, we try to do it as gentle as possible. But once the baby's out and the baby's fine, then everybody should slow down. Okay, this is good. Okay, here's your baby, skin to skin. Let's cuddle, and then we'll go into the relax mode.
Now, myself and Maren both actually gave birth during COVID. So we were actually in that period of are our partners going to be allowed in or not? So when it comes to either planned or unplanned C-section, our partners actually allowed in the room with the moms.
Yeah, I think it's called family-centered care, and it's in most hospitals in Holland. So we think the family should be together all the time. Also in emergency settings, also in reanimation settings. In every setting, at least one parent should be there, but better the whole family. So that's what we do. Even in our trainings, so we train these emergency C-sections. We have one person, one of our staff, who is actively informing the partner during the emergency. So he does nothing else, just informing the partner. Saying, this is going to happen. This is what they're going to do with your wife. This is what we feel. And now we're going to do the operating room. Just keep on informing. So we find that really important.
That's
Optional
nice.
communication.
Yeah. Is there anything that you can give as tips to partners to be part of it? Not maybe in the emergency situation now, but with the elective and more time and more space, if there are any tips where you say this is something that really helps us as a team, but also the mother?
Yeah, well, they should be prepared, just like mothers. So think with your wife about your birth plan. So go through the most likely scenario, so don't be surprised. But there's not a lot that you can do. Just coach your wife, motivate your wife, and even most partners afterwards, after emergency C-section, a lot of partners who think they're useless or really have a lot of guilt or worry because they stood there, could do nothing. So that's why we try to actively involve them in an emergency or an unplanned C-section. Yeah, be prepared, I would say to them. Yeah.
I've got a really stupid question here for you, but I'm just going to throw it in because in the wish list or the planning your birth plan. So it's always like, oh, what you want? People are like, oh, I want candles or da, da, da. Question for you. Now, I've seen in movies where some doctors like to play opera music or whatever. Can the mom choose to listen to Taylor Swift if she wants during that surgery? Or is that your choice?
Taylor Swift?
I'm just sure. I'm going with the age here, listener. So
that's perfectly fine. During delivery or during C-section?
During the C-section.
We don't have a lot of requests for music, but sometimes we do, and that's okay. In an unplanned C-section, there's a lot of stress. So most women don't like music. It's not Taylor Swift. It's usually something...
ocean waves.
Yeah, it's something relaxing. But we also have women who say, can I have 1 minute to pray before C-section? Of course. Or just a minute of silence because I lost somebody there and this is a special moment. Sure.
I also wanted to just ask also about doulas. So the partner and a doula would also be allowed to be present. So it'll be 2 people for the mother.
During delivery, lots of women have doulas nowadays. So I think it's good. It's really good. We know from scientific research that one-on-one guidance during delivery actually improves your outcome. So unfortunately, our insurance company doesn't cover the cost. So it's not available for everybody. So I don't like that, but hopefully in the future. However, I would like them to have them in the operating room because they know these women really, really well and can, especially when it's unplanned or emergency. So they can really be of a great additional value. But sometimes we need other people in the room, such as a pediatrician or maybe 2, and there are only about 10 people allowed in the operating room. Sometimes you have to skip. So occasionally we do. We say, okay, this is so important. We need to get the doula inside. And sometimes we just can't. There are too many people. And then you get a risk of infections or most of the time infection. That's the highest risk if the operating room is too crowded. But we're trying,
So we're going to move into one of your specialization, which is actually the mother-assisted C-section, which I only found out about, I think, last year or something. And I was just blown away by some of the pictures, which you can actually find on your Instagram.
Mhm.
It's stunning, simply put. It really is so magical.
Thank you.
So can you actually
And
explain
it's
to us?
beautiful because so many times, and yeah, I've read this hundreds of times, that when a C-section is in place, elected or not elected, a lot of times women feel like, oh, I haven't given birth really, or I haven't really done it, or like they feel like they're missing
Yeah.
something from this whole
Mhm.
experience.
It's not true.
So I saw this, I was like, wow, this is hopefully getting out there, because this really shows that no matter how you give birth, you're always putting in all the effort and all the work, and there is no better or worse birth.
Wow. Yeah, true. Thank you. Yeah. That's
Um,
exactly what we're trying to do.
Yeah. So can you actually let us know what are the options for moms who actually prefer to do this, to look into it and to experience it? Because I don't know many places. And I know, I think Elena actually even mentioned you in Utrecht. I think she might have been part of one of them. You're in Utrecht, but do you know if this is a standard then across the country?
No, not yet. So although since more and more people know about mother-assisted C-section, there are more and more requests also in other hospitals. So the pressure is building. Some hospitals are a little hesitant and they find it difficult to get these procedures done. Also, hey, you're in a team, so you need to convince everybody that this is a good idea. But the last years I noticed some attention from other hospitals. I recently had a really nice colleague from Amstelveen, which is pretty close to Amsterdam, and she now performs the mother-assisted C-section. Dr. Koning is her name. So we'll get there. So we have about 500 to 600 C-section in our hospital, and I think maybe 50 mother-assisted C-section. So most of the women are really enjoying that it's available, and they think it's lovely. But most of them say, well, it's not for me. It's for somebody else. That's okay.
Can you then highlight what are the associated benefits and risks then?
Well, we did some research, which is not published yet, but where I compare 100 mother-assisted C-section and 100 normal C-section, the gentle C-section, all performed by me. And we didn't see any differences in complications or blood loss or temperature of the baby or APGAR scores. So the procedure is safe and just as safe as regular C-section. There's a couple of differences, especially it takes a little bit longer because you need to dress the women like me. So we're just colleagues. So she also get a operating gown and gloves, and so it's kind of fun, by the way. So it takes about 4 minutes extra of time. We do see a lot of compliments afterwards. So women are really empowered, especially when they've lost someone or they have traumatized or they have traumatic experiences. They are really empowered. They get lots of emails and also with pictures from years later showing their daughters now 5 or 8 or whatever. And they're so happy that they opt for mother-assisted C-section. So no, it's not safer for you or your baby, but it's a wonderful experience. So it can empower you. It can make you happy. So, and I think it's something we don't look at when we check our boxes for, is this a safe procedure? But if we had a box which says, our mother's happy, I think we would have scored really high with this procedure.
So you mentioned there like 5 or 8. When was the first time you actually did this?
About 8 years ago. It was not my idea. So there was a woman, a very brave woman, and she thought it was a good idea to give birth by a mother-assisted C-section. So, and she brought with her doula, and doula, I know her. It's Annelies Mulder, and I knew her for years. So she was smiling when she came in the room. She said, "I got something for you now." So and she explained to me that I've heard about it vaguely, so but I'd never seen it. So I said, "Well, and she really convinced me that was something which could really help her with her traumatic experience. So I was willing to try. So first of all, I was looking on the internet for clips, or no, there's nothing there. So just a few fake clips. So we need to invent this procedure. So we had a couple of very enthusiastic colleagues, and anesthesiologists and some assistants from the operating room, and just the 4 of us. And we had a 5th who were putting on the operating table with a big doll underneath her clothes. So, and then we start preparing the surgery. So how can we make it possible to get your baby out? So how does it work from entering the operating room, get dressed, but also don't lose too much time because you get a spinal anesthesia, your blood pressure will lower, so, and your baby will suffer if it takes too long. So we had a time interval. So it was a lot of fun. So and finally we did it. So, and then she came to our hospital and we did all we practiced, and she was ready. And we were all very happy because it works. And she said, oh, you've done it before. And we never done it before. We trained it a lot. So, and then she helped me getting her baby out the first time. And when that happened, the whole operating room was quiet. So everyone was, wow, this is special. And I was also, wow, this is really special. I couldn't imagine before that this was so special, so nice. And that's when we thought, well, this is something we might need to offer to other women. So, and then the media picked it up. And then it started growing. And now we're started with once a year. And now we're at 50 a year. So there is a group of women who really like that, but there's also a group of women who really like it, but doesn't opt for it. So, and that's okay.
Not always have to be for everyone, but like your ultra marathons that you do, it's a wonderful idea, but I just won't do that. When we look into the post-op care, can you give us an idea about what post-op care is provided to the mothers who actually undergo these in the Dutch hospitals themselves?
Well, usually when your surgery takes about 2 to 3 hours in total. So we have this family-centered department. So with your own private suite, a family room, and you start there, go to the operating center, get your C-section, then you come back. That takes about 3 hours, 2.5 to 3 hours. And then you stay with us at least 24 hours. It used to be 36 hours, but we noticed that a lot of women wanted to leave after 24 hours. So we said, yeah, well, that's a little early. Are you not too much of pain? And we still need to lower your pain medication, and you haven't been out of bed. So now we made a fast track protocol for these women who really want to go home. That's okay. So we start mobilize them a little bit early. So 24 hours, but that's, I think, the bare minimum. Some can go home because a little bit pain, or they're nauseous, or they have complication, or their baby needs extra care. So they stay with us till 36 hours, and sometimes even longer, 48 hours, if we have to observe the baby when they use medication, or when the babies are small or big. And then usually we'll keep an eye on them for 6 weeks, but not actively. So we don't invite them actually to the hospital, but they can call us 24/7 whenever something happens. And after 6 weeks, we offer them either a physical appointment at the hospital. That's really nice because they always bring their babies. But we also noticed since COVID that a lot of women don't like to come all the way to the hospital just to talk. So they say, if you want to do something, fine, I'll be there. But if you just want to talk, I'd rather have phone. So we have a lot of telephone appointments after 6 weeks. We also tried video calling, but most of the maternity women, they say, I look like a mess. I don't want to be on your video. So I'm just looking at a black screen. That's okay.
Wow. Okay. I'm really actually shocked that it's 36 hours and some people are actually wanting to leave after 24.
Yeah, I was surprised too. I wouldn't have thought that women would like that, but especially when you're experienced, you have maybe 1 or 2 kids at home. So, those women really want to go home. They want to be with their family. They know their alarming symptoms. They are experienced. Usually they have a good care around them, organized with friends and family. So beforehand. So, but if it's your first, it's a little bit quick. So
what's the max then a person will be allowed to stay, for example, under their health insurance?
Well, whenever you have a medical indication, you can stay as long as you like. There have to be a reason to stay in hospital. So we're not a hotel. No, it's not.
Fair enough.
But if you have a complication, you stay as long as you need to. So we have women who stay 5-7 days sometimes. Rather not, because they usually have severe complications, such as an infection, or sometimes when their babies are really sick, they're transferred to the pediatric departments to stay with their sick ones.
So you were mentioning there that they're under your care for the first 6 weeks. So it's very much like our verloskundigen ourselves when you give birth at home or equally in a hospital or a birthing center. So women tend to be actually recommended to see a physiotherapist to help with the numbness or sensitivity when it comes to C-sections. Can you explain to us a little bit about why there is numbness or why there is a sensitivity?
Sure. Just a little bit addition to your previous question, because I don't do that alone, these 6 weeks. We work together with kraamzorg, the maternity care, and met the verloskundige. So they usually visit you the first days at home. So they take care of you. So, and if they find something alarming, they call me. You need to see them. Your last question concerning the recovery of the wound, and it depends on, is it planned or unplanned, and what condition are you, and what did you have any complications during pregnancy? So that all depends on how you will recover. Usually most women recover without complications, so lifelong complications from C-section are very rare, but you can have complication which can extend your recovery time. So from 6 weeks to 8 weeks or 10 weeks when you have a bleeding or an infection, or you have accidentally damaged one of your organs during C-section. I'm not actively advised to go to a physiotherapist. I think they're very useful, so I wouldn't be against it. And they can help you train because your pelvis is really softened, so it's very unstable and your muscles are really loose and you haven't trained them for a month. So, and you need to rest for 6 weeks. And considering the numbness, those are usually nerve damage. So when we cut, we also damage nerves, and they take a lot longer to heal than normal tissue. So numbness or tingling or cold or warm sensations are pretty common, sometimes for months.
Months, you said?
Yeah, sometimes. That can take a long time.
But no one can do anything about it. It's just about the body healing itself.
Yeah.
We talk about recovery more. When would you advise if someone had elective or non-elective C-section, if they want to have another child, what's like the minimum they should wait, or do they have to wait, or what is the procedure for that?
So if you're planning another pregnancy after C-section, we advise them to wait at least a year
to get pregnant, and then
and that's for multiple reasons. Pregnancy within 1 year increases your risk for growth restriction, hypertension, and if you getting pregnant within a year after C-section, your scar in the uterus might not be healed properly, we think. So the risk of a rupture of vaginal birth is increasing. So, but sometimes women say, well, I'm over 40. I don't want to wait that long. I'm not going to give vaginal birth. I'll take my chances, get pregnant within 1 year, and then you plan C-section for me at 39 weeks. Yeah, and that's something we discuss, and we call that preconception appointments. Sometimes women come to me to discuss these options. So we weigh the pros and cons from getting pregnant within a year. But usually wait a year if you have the time. That's the safest for everybody.
I have absolute admiration for anyone who can have two children in the space of even 18 months, let alone 2 years. I mean, it's incredible.
Usually when we have these talks 6 weeks after birth, I also mention their future child wish, and they also look at me, what are you saying? Go away.
I haven't slept. What are you talking about?
What are you talking about? But then saying, well, I probably won't see you before that. So this is my last chance to tell you this.
Wow. So when we've we've done a little bit there about like physio and other effects after post-op. Can we quickly ask you about breastfeeding, for example? Are there any specific guidelines or recommendations for breastfeeding after a C-section here?
Well, we do see after planned C-section that breastfeeding is a little bit more difficult because your body hasn't experienced birth. So some hormone levels are a little bit low. So it can slow down the production of milk. So we offer in our hospital everybody who has planned C-section prenatal pumping to start up the production of milk. Sometimes we ask them to stop when they have a lot of contractions, and especially those women who have a primary C-section and also have a higher risk of problems with their production of milk, such as diabetes, or maybe their baby needs a lot of milk because they're big babies or they're multiples. So we really advise them to start prenatal pumping, but it's very successful, so we now offer it to everybody.
So when you say prenatal pumping, is that actually colostrum harvesting?
Yeah. Oh, is that? I haven't heard that term before, but
it's maybe
sounds the same.
Okay, because for example, when I tried to do it, like I'd never heard you can actually use a pump with that, because they were like, that's too damaging on yourself. And so I'm surprised you're saying, is it an actual pump that these women will be using?
It's a hand pump, I think.
Okay, good to hear. Yeah, the colostrum harvesting, I'm sure we'll do an episode on that, because I find it absolutely, it is literally liquid gold.
I'm not an expert on that. Yeah, just one bit, but after unplanned C-section, most of the women did have some contractions, so they usually have less problems with breastfeeding, if they want to, of course.
So it really is that experience where your body is going, hey, that's actually the whole change.
Yeah.
So you were explaining there that you yourself have actually done a little research that's not published yet with the 100 births, mother assisted or not assisted. Is there any other research or advancements related to either cesarean or mother assisted cesarean here in the Netherlands?
That's a pretty broad question. I'm sure there are lots of research. We always are looking into what's the best option for women when they have a breech, when they have twins. What would you do with the second twin? Is a C-section a better option? When do you plan a C-section when there is a placenta previa? So there are lots of lots of research going on, considering the timing or the procedure of C-section. So, and that's why our protocols change every year or every 2 years there. And then we change, and then we'll offer that in our counselings. The major change are the gentle approach. That was 10 years ago. You just showed the baby just above the curtain. So this is it. This is him. So, and off he goes to dad. And then upstairs, yeah, that's really, but we thought it was really normal, and the mothers too. And then I think about 12 years ago or something like that, I tried to introduce the gentle way in our hospital, and they were like, why? And now 12 years later, everybody's really upset if the mother and the baby are separated. So, it's so poor mother. So that has changed a lot, I think. And also I think it changed that C-section can also be a nice experience. So like birth, yeah? You can really try to make it a really happy, beautiful experience for women. So that changed. Procedure-wise, I think we still cut the same layers and stitch the same way. The anatomy hasn't changed though.
I wanted to jump in there with the topic of placenta. Is there anything, so because some women choose to proceed further with their placenta in many, many different ways, is there any difference when you have a C-section, elective or non-elective, when it comes to the placenta? Is there anything that's not possible anymore with it, or can you even have it, or what's happening with the placenta?
Everything is discussable. So you can, if you think about things you want to do with your placenta, just tell us so we can think with you. Well, what we do recently, I think the last years, we do a delayed cord clamping, like we did with normal deliveries. We try to do that with C-section. It's a little difficult with unplanned C-section because sometimes the condition of the baby doesn't allow delayed clamping. But with planned C-section, it's pretty easy. So, and especially with mother assisted, because the baby is skin to skin with the mother. So, well, they're good. So they can wait very long. During normal gentle C-section, they have to wait to take their baby until the cord stops pulsating. So sometimes they're eagerly waiting behind the curtain. So get me my baby. So that's what we try to do. And we usually, after birth, we ask the parents what they want to do with their placenta. Sometimes we find a complication during pregnancy where we ask them if we can do some examination on the placenta, pathology examination, maybe if they're impaired function or abruption, so blood loss or other things. And sometimes parents want the placenta to take home, do any rituals or make art. Well, if you look at Instagram, so there are many ways, many possibilities.
So that's all still possible, all with the C-section, if there's no special
sure, placenta. Yeah.
Take the baby home, you take the placenta home.
It's not mandatory, but
but also nice to
we collect them and we'll just
to hear with the delayed cord clamping, because that was in my head. It was a question, but then I thought, is this like a logical question I could ask? So great that you brought it up, because that was
it's a good question.
I was like, is this possible, delayed cord clamping or not? So
it's a little cold in the operating room, so you can take
true.
like 5 minutes or so, and the mothers want to hold their babies. So
In lead on to the placenta question, I was just wondering, do you actually do stem cell donation? Can you do that with C-section as well?
Yes, I think in some hospitals they do. So I think in Holland there are a couple of hospitals designated to perform stem cell donation. So, and we were not selected. So I'm not sure how that procedure works, but I think after birth of the placenta, they withdraw a lot of blood, as much as possible. And they put it in this special bag and send it to the stem cell bank, I think.
Yeah, I think it's Sanquin is the only one left.
Yeah, I'm not sure if there are still some clinical use yet, but maybe in the next decade or so.
So, as I said at the beginning, there's a lot of conversations about from international families of the women who come here and they're pregnant, they're going to give birth. And there's that thing of we feel like we're stopped from giving, like cesareans are not an option for us because of the home birth here. But is there actually any concerns from the Dutch healthcare system about an overuse or underuse of cesarean here?
Yes, a little bit. There is a ideal C-section percentage from the WHO. So countries try to reach that. And we don't want it like other countries where sometimes there are percentage like 50 or 90%. And there's also a lot of damage. That baby might be safe because you had planned C-section, but your body has had serious damage, and future pregnancies will be more complicated. So in the end, I'm not sure how it works out in the long term. So back to your question, yeah, there is a little bit of pressure by our colleagues. So we try not to do too much C-section. So you probably feel that as a foreigner, and you probably also feel our culture, which is home birth based. I imagine 20 years ago it was about 25-30%, a lot of home, way more. So we're going down now in home deliveries. It's good because we now selected the women who are really good at delivery. So you can go home, you can do it really well. So that's a good thing. But on the other hand, I think we should not look at the percentage, because it might not be the best option for everybody. Some women just need a C-section, and sometimes they're not on the medical indication list. Well, that's too bad for the list, because it's not the best option for her. So, and that's what it's all about. So give the best care, even if it's not on the list.
So nice to hear a
Amen.
doctor speak.
Yeah.
Thanks.
It's so refreshing. I guess the last question I have right now are there any initiatives or programs to promote informed decision making regarding cesarean sections, or do they need to still speak directly with yourselves, OB-GYNs?
Yes, they usually need to talk with us, because we're going to perform the C-section. So I would like to meet the women who opt for C-section, and like with counseling about C-section, but also counseling about breech or twins or everything, we have shared decision making. So sometimes we have these lists of questions. I usually advise women to use the brain method. Have you ever heard of those? Okay, great. Mm-hmm. So whatever a doctor asks you or advise you something, just throw back the brain. So it really helps you on what's in it for me. Why is it good for me? So, and then you can really make a good decision. So that's the basic, I think, of shared decision making.
Is there any websites or organizations or stichtings or anything you're aware of that could also help women answer questions for themselves?
Not specifically. So you mentioned Ouders van Nu. That's something, that's a good, reliable source. We also have the verloskundige and de gynaecoloog.nl. So those are really good websites. So, and of course, just browse, just Google, just go ahead and find whatever you think you're willing to seek. I don't mind.
Google can be dangerous. That's the problem.
No, it's only dangerous if you act upon it without consultation of experts. So Google. So I have met a lot of women who Googled their diagnosis, but then I know where they're afraid of. Then I know where their concerns are. So it's also good for yourself to learn, what am I actually afraid of? And that's how you Google. Google is fine. Just
I kind of feel
discuss it with an expert.
I know. I kind of feel like you are like a psychologist, OB-GYN, the way you approach things. It's so refreshing and nice, and how open you are. Because I know a few people have been quite caught off guard, I guess would be the only way, when they've gone to talk about having the operation, having a planned C-section, as it were, and they left not feeling very happy with what was happening. And obviously, when you leave, just even that talk, all you can think about is my birthing experience is with this person. And then that's already casting this grey shadow all over you.
Yeah.
Is there an option to change doctors?
Yeah. Well, it's written in the law that you are allowed a second opinion. So if you're not happy, not that you don't like your doctor or you hate your doctor, I offer second opinions also when there is a difficult decision to make. So you might want to listen to another doctor, so see what he has to say, especially when it comes to early deliveries or something. So that's good. And you can also ask your midwife. Your midwife knows a lot of gynecologists, and we have a very close contact with all our midwives. So I get a lot of text messages just to discuss little things. And they ask me, so this woman has been to that hospital and they think she might want another opinion. Would you be happy? And then I can say, yeah, sure. Or maybe you can go there. They're more experienced with that. So that's how we work together. But if you're not happy with your decision making, or you're not happy with the results of your appointment, you should speak up.
Yeah, that's what
but
this
it's
podcast
difficult.
is. Yeah, we're trying to make people know that they have that decision, and these are, and hearing from professionals to say it themselves, like speak up. This is really important for everyone to know.
Yeah, and if you find it difficult, just ask your midwife. She knows how to handle us. She knows how to talk to us. They're they're really great team players, the midwives. So I think if you think it's difficult, ask them.
Thank you so much for joining us here. It's been really informative. And I know this is such a heavy podcast for even us chatting here because it's quite focused here and our listeners as well. But I'm sure this is going to be a podcast. Many people who are pregnant are going to probably listen and pause and go back and review. And you've really given us quite a lot of facts. So thank you so much for that.
Oh, no, it was really nice to be here.
And that is Dr. Koen Deurloo. And if that conversation didn't make you want to go find him on Instagram right now, I don't know what to tell you. He's at KLDLOO. He's the real deal, and he's one of those rare people in medicine who actually listens. You can also find him as an expert voice on Ouders van Nu and How About Mom, both incredible resources if you're navigating pregnancy and parenthood in the Netherlands and can speak Dutch. But that's why the Damn Parenting podcast is here, because most of us can't. And here's what I want to leave you with. You're allowed to advocate for the birth you want. You're allowed to ask questions, push back, and say, actually, I would like to be part of this. A cesarean is not a consolation prize. It is a birth, and you deserve to feel that. At Damn Parenting, that's the whole point. We are here to have the conversations that help you make the decisions that are right for you. Not for your neighbor, not for your midwife's preference, but for you, your baby, your family. If this episode resonated with you, share it. Send it to a friend who's expecting. Post it. Because Cesarean Awareness Month only works if we are actually talking about it. Loudly, openly, and without apology. Thank you for listening. I'll see you next time.